I'm curious, if you had a letter you wanted to write to your dean, what would you ask him to do in terms of curriculum and education as far as solutions towards this crisis?
So I love the question. what would I say to the dean? So first, the whole addictions issues need to be addressed across all 4 years of the medical school curriculum. And there are wonderful opportunities for doing that. It's at the cutting edge of science, so there's no reason that there aren't great opportunities early on to be talking about the neurosciences. It's at the critical area of epidemiology and public health. And as you think about that and the ways in which it then fits with the person and society, which is a critical part of a medical school curriculum. And then every clerkship, so every one of the medical specialties and subspecialties deals with pain and deals with substance use and sees people who have pain or substance use, and to be able to make sure that in all of those curriculum there's an addressing of these issues. Substance use, pain is an important part, and there are opportunities for doing it. And the good part is that there's an enormous willingness here to do that. And there's a great interest. And so that's part of what makes this panel exciting and makes being at Howard exciting is, we're sitting here across different schools and all of us saying we've got these important issues to be looking at together. And within the College of Medicine, there are then the opportunities across departments and disciplines to be addressing these.
At this time, I'm going to invite Ms. Powell. She's going to help us with giving some gifts to the speakers that participated in the first session. Thank you.
Good morning. I'm Howard's Director of Government Affairs, and we are very pleased that all of you were able to join us for our first Opioid Symposium. With that said, Dr. Moore, thank you so much for participating.
Thank you very much for having us.
Thank you so much.
Thank you so much for participating.
Thank you. Where's the photographer? Oh.
Thank you.
Okay. As we continue into session number 2, I am going to introduce our distinguished guests that will help us even as we continue this conversation around precision medicine, treatment, and regulatory prescriptions for opioid use disorder. I have with us Dr. David Thomas. He's the Health Scientist Administrator for National Institute on Drug Abuse. Let us give them a welcome as they come through. So after 12 years as a pain and opioid researcher in 1995, Dr. Thomas joined the National Institute on Drug Abuse, where he has managed much of NIDA's pain and opioid research efforts. In 2015, he joined DESPR's Services Research Branch, and he currently is co-chair of the NIDA Prescription Opioids and Pain Work Group, which fosters pain and opioid research and education. Please welcome Dr. Thomas. Our next distinguished guest is Captain John Wesley Hiraldi, and he is currently on the Professional Affairs and Stakeholder Engagement staff at the Office of the Center Director, Center for Drugs Evaluation and Research of the U.S. Food and Drug Administration, FDA, in Silver Spring, Maryland. Previously, he was a medical officer in the Division of Anesthesia, Analgesia, and Addiction Products at the FDA, where he was a member of the Opioid Action Plan implementation team. His responsibilities include primary medical review of new pain drugs for pre-market approval in the US and safety approvals of clinical trials for investigational new drugs in pain and addiction. Let's welcome Dr. Hiraldi. Next distinguished guest is the branch chief for genetics, epigenetics, and developmental neuroscience branch of the NIH. Dr. Pollock manages and oversees all activities of the GMNRB. Dr. Pollock continues to advocate for genetics, proteomics, and developmental biology research at NIDA. Under his leadership, the NIDA Genetic Consortium was established that led to the discovery that the nicotinic receptors ChRNA5, ChRNB4, and ChRNA3 are associated with nicotine addiction, lung cancer, and peripheral artery disease. He also took a leadership role in the development of the Knockout Mouse Project. He plays an active role in the NIH Brain Initiative on the cell census, and his portfolio focuses on the genetic and epigenetics mechanism of addiction in humans and models in the non-human organisms. Please welcome Dr. Jonathan Pollock. And the next distinguished guest that I have is Dr. Regina James. She's Director and of Clinical and Health Services Research at the NIMHD. Dr. Regina James serves as the Director of Clinical and Health Service Research in the Office of the Director at the National Institute on Minority Health and Health Disparities. In this capacity, she is working with intramural and extramural staff to establish a clinical trials database, research monitoring policy, and research resource toolkits to facilitate monitoring and reporting of NIMHD clinical research and clinical trials. She is also representing NIMHD for the NIH Precision Medicine Initiative and co-chair for the Community Engagement Health Disparities NIH PMI Working Group. As you can tell, all of these individuals are very distinguished, and I only read a snippet of their bios. Please welcome Dr. Regina James. I'm going to be in the middle. So as I join them, just to frame how this session will go, a little bit similar to the first session, they will have individual presentations. They have slides for you to see for a change. And then we will go through a few questions that they will be answering, and then we will open it up as well to the audience. So we will get a sense that you have questions for us when you stand by the mics. We'll give you a little bit of a warning so that you know when it's about time to begin to welcome the audience's questions. Thank you again for participating with us today. So the first speaker today is Dr. Thomas, and he will be sharing a few minutes about his work. Thank you.
Good. Good morning. I'm Dave Thomas. I'm with the National Institute on Drug Abuse, the NIDA, as we like to call it. NIDA not only is concerned about drug abuse, but we also have a very large pain program. And I'm very involved with both of those, the opioid and the pain program. So we're right in the middle of this crisis, trying to help. Nothing to disclose except I'm a pain researcher by training, and I care about drug abuse and about people in pain. And you'll see that. I'll make that very apparent, I think, in this talk. So first of all, let's talk about pain in America. It depends how you define pain in terms of real severe pain or moderate pain, but there are about 100 million Americans, according to the IOM, in serious pain, in persistent pain. Pain is a huge problem to our country. You don't see them always. They don't identify themselves as being in pain. You don't always want to let people know you're in pain, but they're all around us. We all know people in pain. What it costs our society, it's hard to read, but it costs our society in terms of lost wages, taxing the medical system and other things. Beyond just the human suffering, it costs us about 2/3 of $1 trillion each year. Now that's more than the U.S. spends on the military. It dwarfs any other condition. And let me just add that pain is a sensation, it's protective, but it can also become a disease. And this disease, by far, is the most expensive disease that we're facing. If we look at, this is a couple things put together here on this slide, but if you look at the bars in this slide, it's the death rates from opioids. And it has been escalating, and it continues to escalate. Projections for 2017 looks like it's getting a lot worse. But pain has been escalating too. In about a 12-year span, the number of people in pain in the United States doubled from about 50 million to 100 million. Imagine any other condition where the number of people with that condition doubled in such a short time. That's a crisis too. That's an epidemic. Why? That's a good question. We could talk about that. There's different reasons, but it's something we have to manage, and not taking care of it. What we've done over the last few years is tried to use opioids as a quick fix, and it didn't work. We have to do better for people in pain, and we don't. Let me just show you this slide about how much pain is taught to medical students in the United States. I won't go through it point by point. I have to be quick, but about 9 hours per 4 years of medical school education in the United States goes to pain. I looked up, a few years back, I looked up all the courses across all the medical schools that had pain in the title. I found one. Canada does better. They teach about twice as much pain as we get in the United States. But veterinarian schools, they get about 10 times more treatment of pain. And again, remember how big pain is, how many people are suffering, what cost it has on society. And then we don't train people about pain. We also have a problem with measuring pain. This kind of came up in the first talk. We don't have good measures of pain. We have smiley faces. And smiley faces, or just me telling you what my pain is on 0 to 10 scale, I might say it's a 10. It's the worst pain I ever felt, but I never had a baby. And what I call something, somebody else calls it different. It impedes treatment, it impedes diagnosis, and it's something we have to do better with. My analogy is if you went to a doctor and said, I feel warm, they wouldn't point to different fires and say, which fire is you? Well, I feel like a pretty big campfire. No. You would ask them if they feel warm, and you use a thermometer to find out their temperature. We can do that better for pain, because pain is real. It's not subjective. It's not something that doesn't have a biological basis, and we have to do a better job of studying pain. So, the crisis, and this is... my opinion is how we got into this crisis is the same way we get out of it. And my view on this, and there's I think there's a fair consensus on a lot of this. This isn't the whole story, but I think 3 of the main drivers were that we have poor clinician training. I showed you that. They get almost nothing on pain. And by the way, almost nothing on drug abuse. Minimal reimbursement. Opioids are reimbursed. They're cheap. They're reimbursed. It takes you 30 seconds to prescribe an opioid and 30 minutes not to. They're an easy way out for people that don't have much training in general. And third thing is poor tools. We don't have the magic bullet. Opioids have issues, but so do NSAIDs. I mean, you can cause renal failure. There's not a really, really good treatment that just stops pain. No magic bullet here, so we have to be better at treating pain. And on top of that, we pushed opioids as a cure-all, and that was a prescription for disaster, if you will. Okay, so what are we? I'm at the NIH. What are we doing? We've been doing this for a while. This is suddenly in the news, and it's big, a lot of press, a lot of interest in the opioid crisis, a lot of concern. This is great. I was at a similar meeting on Monday at Hopkins. They're doing the same thing. They had President Clinton there. They're doing the same thing. And that's great. But we've been working on this for a while and really trying a number of efforts to stop the epidemic of the opioid crisis and also reduce pain. Some of the things we did, one of the things, pathways to prevention, we just had this large effort to analyze, critically, unbiasedly analyze the literature and see what we had. We literally had a jury look at the data, and they concluded, because otherwise people were just arguing back then, opioids are good, opioids are bad, and they're just fighting. Let's see what unbiased analysis gets us. And they concluded we don't have evidence that they work long-term or that they don't work long-term. We just don't know. So we need more data on that. At the NIH, we're running a Centers of Excellence in Pain Education, trying to promote better pain education in nursing, pharmacy, dental, and medical schools by creating online educational materials. The FDA is mandating pharma to do post-market safety studies, and we're involved with that, trying to keep an eye on that. That's the study we don't have. What if somebody takes opioids, they're not addicted, for pain, and they take it for a year and a half? Do they become addicted? We don't know what that number is. The estimates out there are anywhere between 0 or 44%. And we just don't know. We have to have a better idea who's going to have problems with opioids and how many people will. And that will help us prescribe better. The pain-o-meter, we have a solicitation on the street right now to help develop some objective measures of pain, and some really cool things are out there that might give us better insight into a person's pain and what treatments might work. We participated with the CDC guideline on opioid prescribing, which basically said we're overprescribing opioids, have to give less. But the NIH also participated in the National Pain Strategy, is saying, okay, you're taking away opioids, less opioids, but let's do that other thing. Let's take care of people in pain better with other sort of treatments. And I see those two efforts as complementary. And now the most recent thing is the NIH has, I know the president declared this a state of emergency, I guess that was. Well, the NIH is following suit in a big time. It's our #1 priority, opioids and pain. We had a workshop. There's the head of the NIH meeting with experts over the summer, and we're going to do some real big things in this space to try to find out how do you transition from acute to chronic pain? How do you treat opiate use disorder better? How do you measure pain better? That's now our #1 priority, and I'm real happy about those efforts. And then I think this is important. I've heard this come from a lot of places. This comes out of one of our conferences where we are trying to treat the opioid crisis and the pain crisis together. What we do now, I think what we do now is terrible at how we take care of people in pain. I would like to look back and 10 years from now and just have us as a society realize that was a good thing to do, to put opioids out there and people that don't know how to use them and not reimburse stuff. I wanted to look as absurd as if you look back in old videos of people smoking on airplanes. Somebody could literally smoke a cigar next to an airplane, and you could ask them, if you were bold, to put it out, but they didn't have to. I'd like us, what we're doing wrong isn't working. I think it's bloody obvious with the crisis, and we need to do better. And that's it. I would just like to add one more thing. We have an opioid crisis, but we also have a drug abuse crisis, too. Cocaine is starting to shoot through the roof in terms of deaths, especially in African-American people. So let's not forget about some of these other problems, too. Thank you.
Thank you, Dr. Thomas. Next, we have Dr. Haradi, who's going to be talking to us also about.
Good morning. Thank you, Dean Tafade and Howard University for this invitation, and I'm truly excited to be here to discuss this very important public health crisis. I have nothing to disclose, and the lawyers say I have to say these are just my views and not necessarily the agency. So, what are we doing about opioids? You've heard from Dr. Miller earlier on, and some of the information may be a little repetitive, but probably a good thing to reinforce the importance here. We've all seen the risk of opioid use, misuse, and abuse, and we've done some things over the last year, and I'll touch on that a little bit later on about our opioid action plan, but that include labeling changes for pharmaceuticals, warning letters, workshops and public hearings to get more input on the approval process. We've also engaged more advisory committees, and I'll talk on that a little bit later. And looking at, you probably heard this, abuse deterrent formulations of current opioids, as well as what Dr. Thomas said earlier about post-market safety studies that we're looking at. Believe it or not, these things have been going on for about 15 years. Granted, probably not with the urgency that we need right now. So where are we right now? You've seen this, 2 million Americans abused or were dependent on prescription opioids, according to the 2014 studies. 10 million are using it for non-medical reasons. And from 2015, about 33,000 deaths from opioid overdose. That's about the average attendance at a Yankees game, just to give someone some perspective. Unfortunately, we're compiling the numbers for 2016, and the preliminary results are that it's even higher than this. So we have real problems to fix here. You've seen this also from Dr. Miller, just reinforcing it again. Only 20% of people who abuse prescription opioids get it from a physician or a healthcare provider. Almost 7 out of 10 get it from friends and family. And he also talked about gateway. Prescription drugs are often a gateway to street and illicit drugs. Among new heroin users, about 3 out of 4, so 75%, said that they started abusing prescription opioids before starting on heroin. So where are we in this war against this epidemic? Are we winning? Well, first I'll give you some good news. We have made some progress, and this has been mentioned by panelists before me, that prescription opioids have actually gone down as far as from 2013 all the way to, I don't know, can you see that? Sorry about the size of that graph. But from 2013 on, the total number of prescriptions have gone down. Unfortunately, as you can see with the deaths, that has not gone down. Although you will see towards the end here, again, I'm sorry about if it's not too clear here, but as you can see, while the total number of opioids deaths have gone up, the prescriptions have leveled off. It's mostly now from illicit drugs, heroin, and the very steep one right there in orange is fentanyl and carfentanil. So what have we done? I mentioned earlier about the opioid action plan that FDA initiated back in February of last year. And this is to look at policies aimed at reversing the epidemic. But then again, we cannot forget that there are still patients who legitimately need pain medications, and to find a way to not restrict access to them as well. To talk really briefly, I'll just go over some of the components of the action plan. I mentioned advisory committees. We'll talk briefly about changing the immediate release opioid labeling, some post-marketing studies, this risk evaluation mitigation strategy that's already been in place for several years now for the higher dose, extended release, and long-acting opioids. And we're going to now include the immediate release, short-acting opioids as well. I'll touch briefly on abuse deterrent formulations, supporting treatment strategies together with the CDC, and re-looking at the risk-benefit paradigm that we always use when approving new drugs. So with the advisory committees, these are panels of academic experts from around the country that we convene, usually for, in the past, controversial and or where we need insights from all these national experts. FDA has decided since April of last year to convene an advisory committee for every single opioid pre-market application. So it's become a real problem here because, one, our committees are getting exhausted, but it shows you how important this is. We want to make sure that every drug that gets approved, particularly every opioid, there's vigorous discussion about what are the risks compared to the benefits. And this includes even labeling changes for pediatric use. Touch on briefly on immediate release labeling. As I mentioned earlier, in the past, we had a risk evaluation mitigation strategy for the higher dose or the considered more dangerous extended release opioids, but not the short-acting 3 to 5 day prescriptions for the immediate release labeling. However, those are actually the majority of the prescriptions, believe it or not. The vast majority of the prescriptions are the short-acting immediate release opioids. So in July of this year, FDA has sent letters to manufacturers of all short-acting opioids, brand name and generic, regarding their participation eventually in the risk evaluation mitigation system that was originally just meant for the higher dose extended release opioids. Dr. Thomas mentioned this earlier. We need more data on post-market opioid use. Unfortunately, the data that's been collected over the last several years have not given us a clearer picture. And I think the President's Commission recently mentioned that FDA has not perhaps enforced the requirements for these post-marketing studies as tightly as we perhaps could have. So those are things that we definitely have to work on. And that includes updating our risk evaluation mitigation strategy that I mentioned earlier, including the immediate release formulations on top of the extended release formulations. Also, to include more education for a broader range of providers. Previously, we focused almost exclusively on physicians, but there's discussion now to include members of the healthcare team, to include pharmacists, nurses, and because this is a battle that we all have to fight together. I'll touch on briefly about abuse deterrent formulations that Dr. Miller had already mentioned earlier as well. And the data right now is still being compiled as far as whether or not it truly is more effective. What we do know, though, is that because it's harder to manipulate, meaning crush, snort, and convert into an injectable form, that has diverted people to use more easily injectable forms like heroin and fentanyl. However, we also have to have that delicate balance, as I said, that at some point, people still need opioids. There's still a select population, particularly cancer patients, folks with terminal illness and in a lot of pain, that at some point we need to still ensure that they get the medication. And how do we get that medication to them while making sure that it's not being misused? Other things that we focused on recently also is naloxone, for example, how to make that more accessible. Thankfully, many states have already looked at making it available over the counter. In fact, in DC and Maryland and Virginia, it is available over the counter, so, or behind the counter, rather. You have to go ask for it. But these are things that we're also looking at innovative solutions and how to make these much more available and aware. And I think that over the years, it has become, especially in the sense that most EMTs and first responders now have carried good supply of naloxone. And we've also recently had a dose, look at different doses, because the initial fixed dose, we realize sometimes may not be sufficient. And so they may require several doses. So that's all being in discussion right now. Again, the guidelines for the CDC have been released recently, and we fully support that, as well as other avenues to better treat pain. I'll just briefly touch on this that I mentioned earlier, where the risk evaluation mitigation system. It's an educational process. Generations of providers have been educated a different way about how to prescribe opioids, and we're now trying to adjust that. make sure that people who are getting them truly need them. So what's next? As you can see, we've tried several things, but there's still obviously much, much more that needs to be done. And we're but a small part, because this is clearly an all-hands-on-deck epidemic that we need everyone, whether it's healthcare providers, educators, family members, and society in general, to tackle this together. And I look forward to a further discussion. Thank you very much.
Thank you, Dr. Haradi. Next up, we have Dr. Pollack to talk to us about his aspect of this opioid epidemic. Thank you.
Okay, so I want to thank the organizers for inviting me here today. As you've heard from Dr. Miller and others, the opioid use epidemic has produced a large number of overdose deaths, and the nature of the epidemic is changing from where a prescription opioid use deaths have plateaued, and now there's more deaths occurring from heroin and fentanyl, and the age of death, it's changed from 40s to 50s now to 35. So I want to really talk about how science can be brought to bear on addressing the opioid use epidemic. So I'll skip these slides. Okay, so morphine, we can develop opioid agonists or new opioid medications maybe that produce analgesia without the adverse effects. So morphine, or its other opioids like fentanyl and heroin, produce their effects through the mu opioid receptor. And these effects include analgesia, euphoria, respiratory depression, physical dependence, tolerance, and addiction. And the gene for the mu opioid receptor is, Is there a pointer? Okay, well, the receptor is alternatively spliced into various forms. So, and by targeting the different forms by a drug, we might be able to engineer a drug that produces only analgesia without producing respiratory depression and addiction. So one example is this drug called IBN-TXA, which targets the version of the mu opioid receptor that only expresses exons 2 and 3. And it's more potent than morphine in producing analgesia, and at least in rodent studies, doesn't produce respiratory depression, physical dependence, or produce rewarding behavior. And also, we can also develop what's known as biased agonists that target the mu opioid receptor lacking exon 7, so that they don't activate the signaling molecule called beta-arrestin, and you have reduced tolerance. Now, this is shown in acute studies. We need to know more about what would happen in chronic studies. So one of the things that we can also do to address the crisis is to develop medications that would prevent overdose or treat overdose. And the mu opioid receptor, the morphine, other opioid agonists act on the mu receptor in the brainstem to produce respiratory depression. And so one of the problems with using naloxone and Narcan is some of the new, or some of the opioid agonists like fentanyl and carfentanil and remifentanil that are on the street are so potent that they might not be able, that naloxone, the antagonist, may not be able to overcome that. As well as you create a crisis, a medical crisis with withdrawal and administering naloxone. So if you give respiratory stimulants to overcome the effects of the opiate, it might be an effective treatment. So some examples of this are the 5-HT1A receptor agonists, and there are also other receptors are responsive to glutamate, such as the AMPA receptor, and there are ampakines, which can also be used to treat respiratory depression, as well as potassium channel blockers, such as doxaprim, almotrin, and GAL-021. And also, there's opportunities for improved treatment for opioid use disorder. So, for example, we can develop new formulations of existing medications, such as long-acting opioid antagonists like naltrexone, naloxone. We can also have developed long-term acting opioid agonists that are typically used for treating opiate addiction, such as buprenorphine or bupropion. Or we can try to repurpose existing therapies like locastrin, which is a 5-HT2C agonist that has been shown in rodents to block heroin self-administration and reinstatement. There are other novel medicines that that can be used to treat withdrawal, the initial withdrawal, such as ondansetron or lofexidine. And then also there may be with transcranial magnetic stimulation opportunities as well to treat addiction. Oh, and the last slide, I thought my slides had been changed. So, okay. So the other opportunity here is really for precision medicine, for pharmacogenomics of opioid pain management. So NIDA has funded, recently a study at Geisinger of 20,000 individuals being treated with chronic opioids for back pain, and because 4,000 have had their medications terminated because of abuse, we can actually, and they've already been the healthcare system has been genotyping these patients. We can begin to identify the genetic variants that confer vulnerability to becoming addicted. And also a whole number of academic healthcare systems now are genotyping all of their patients. So with electronic medical records, for example, we can look at surgical patients who've received opiates post-operative and whose use is only a few days versus those who persist over 12 months, at least to get at the issue of dependence and possibly addiction. And then, I guess among African American populations and also people around the Mediterranean, sickle cell patients who are treated for pain during an opioid, during a crisis and receive opiates, we can also look to see who persists. So I think we have an opportunity, and some of the previous session also talked about electronic medical records and following prescriptions. So I think we have a great opportunity in terms of leveraging data. So with that, I will finish.
Thank you so much. Next up, we have Dr. Regina Drake as she wraps up the panelist presentations.
So, good morning, everyone. Make sure that we're all responsive. What I'd like to do is really take a demographic lens on the opioid crisis, and I'd like to sort of put it in context. So, I don't have any disclosures. But as you know, we're essentially entering our third phase dealing with the opioid crisis. After the Civil War in the 1800s, there was this thing called soldier's disease. It was like a dysentery, fever, chills, and diarrhea, and they treated them, the veterans, with morphine, and some of them actually got addicted to the morphine, and hence there was a crisis that actually came about. The second phase I think we are all aware of was during the 70s, when our neighborhoods were hit very hard. Primarily our men of color were experiencing heroin addiction. And today, starting probably around the early 1900s, there's been a precipitous rise in opioid abuse, use, and the deaths that are associated with opioids. And I'm sure you've seen this figure a number of times before this morning, but there's no harm in reiterating that approximately 90 Americans die each day from opioid deaths. So what I'd like to do is just take a closer look at this. So looking at the numbers and the trends between 1999 and 2015, the number of deaths from opioids has actually quadrupled. So from 1999, it was around 8,000 deaths, and in 2015, it quadrupled to over 30,000 deaths. And if we tease this out and specifically look at heroin versus non-heroin, the death rate from non-heroin overdose, as you can see, tripled from 2.5 to 7.6 deaths per 100,000 people. And then if you look at the heroin death rate, it actually increased almost six-fold from 0.7 to 4.2 deaths per 100,000 people. So again, you've heard these numbers this morning. These numbers are, they're frightening. You know, we've talked about what sort of drove, the factors that drove these, the numbers to the high rates that they are. And again, to reiterate, I think one of the major driving factors was really around overprescription. And so, as was mentioned earlier, you know, physicians were strongly encouraged to recognize and identify pain and to treat pain, and rightfully so. If there is pain and it needs to be addressed, one needs to do so. But you layer that along with the introduction around 1995 of OxyContin, and it was marketed as not only being effective, but not very addictive. So you put those factors together, and unfortunately, you end up with this sort of overprescription. And as I've mentioned earlier, when I started, from a historical context, the opioid crisis of the 70s was primarily an urban minority male issue dealing with heroin. And the opioid crisis of today actually impacts all racial and ethnic groups. But there is a difference in terms of how each of these racial ethnic groups are impacted, as well as the demographics in terms of where the impact is actually occurring. So let's take a look at that. So this is actually a chart of the heroin versus non-heroin death rates per 100,000 people by race and ethnicity in 2015. So if you look at the x-axis on the bottom going across, those are the racial ethnic groups. The y-axis is the death rates. And the beginning, you'll see the overall rate for the non-heroin, which is the dark green bar, is 7.6. And the heroin bar is the light green bar, which is 4.1. That's the overall rate. Now, let me just start off by saying that death rates from non-heroin opioids have increased significantly since 2004, all racial and ethnic groups. So everyone is impacted. But we also have to point out two groups in particular have been impacted much more. The death rates for whites is 10.5, and that for American Indian and Alaska Natives is 9.5. I think it's 9.6, sorry. And actually, that has not been as much of the conversation as it has, as I guess I would like to appreciate it to be. In terms of the impact on American Indian and the Alaska Native populations, as you can see, it is very, very high and significantly greater than the overall rate as it relates to non-heroin deaths. As you look at death rates from heroin, again, the overall rate is 4.1, and for American Indian and Alaska Native populations, again, it is 4.4. Now, this did not reach statistical significance yet. I think this is something that we need to pay close attention to. Again, with the white population, it was statistically significantly higher than the overall rate at 5.4. So again, I think this slide really just underscores the fact that all racial and ethnic groups are impacted by the crisis, but there is a differential impact in terms of, particularly as you look at death rate. Some are higher than others, but all numbers are not good numbers. So we don't want to see any of these numbers on the graph. So we'd like to keep that in mind. As we look at it from a geographic standpoint, so again, the x-axis is representing the location, the y-axis is death rates per 100,000 people. Again, as you look at the non-heroin opioid bar, which is the dark green bar, you will see that in non-metro areas, so this is more like the rural areas, non-heroin opioid death rates were significantly higher there, as well as in the small, medium metro areas. So in the more rural areas, the non-heroin death rates were higher than the overall rate. Now, when you look at heroin, the death rates per 100,000 were significantly higher in large metro areas, but it was significantly lower in the rural areas. So again, there is this difference, there is this distribution. So we are all being impacted as Americans, but there is a differential impact in terms of where we are and who we are. So just taking again a look at this graph, and I'm showing it again to really emphasize the piece about the heroin death rate increasing sixfold. I think the interesting piece is around 2010, where you see this very sharp increase in heroin deaths. And so why is this happening? What's going on? Studies have shown that from among the new heroin users, approximately 3 out of 4 report abusing prescription opioids prior to using heroin. And so why is that? There were, around this time period, more aggressive prescribing regulations being placed. So of course, people will go to the pathway of least resistance. So if I'm being highly scrutinized and I'm not necessarily getting it from my physician, then I'll go to a place that I can get it easier, it's cheaper, and I can still have the same effect. As you know, a bag of heroin, for example, is about $10. But if you buy on the street or illegally, prescription pills are about $30 a pill. So it was much cheaper to actually go into the route of utilizing heroin. Now, it's true that some people did switch from using pills to using heroin, but that's not necessarily the case for all racial and ethnic groups. So if you look at communities of color, for example, they were less likely to come to heroin through prescription opioid painkillers. And multiple studies have actually documented that doctors are less likely to prescribe opioid painkillers to African Americans compared to whites. And even if they did have the prescription, those individuals in low-income neighborhoods find it very hard to actually locate a pharmacy that would actually fill the prescription. So although many Americans have come to the crisis through the opioid pills, not all have come to the crisis in that direction. Some have come, as I've mentioned, particularly communities of color, through just from heroin from the beginning and accessing it either from their surroundings, family, or friends. So that I think is important to point out as we continue our discussion today. And what I'd like to close with is how are we addressing the opioid crisis? I think it was mentioned this morning about on October 26th, the president has now declared this a public health emergency to address the crisis. But I just wanted to just point out some of the Department of Health and Human Services priorities in addressing the crisis. First is having to improve access to treatment and recovery services. This is particularly important for our fellow Americans in rural areas. Medication-assisted treatments such as methadone and buprenorphine are not readily available, and we have to keep that in mind as we think about moving forward and improving access to treatment and recovery services. The second bullet is promoting use of overdose reversing drugs like naloxone. Third, strengthening our understanding of the epidemic through better public health surveillance. Just of note, there was a recent publication this year in 2017 by O'Donnell and colleagues evaluating the enhanced state opioid overdose surveillance program. And I think that was mentioned earlier around fentanyl. They found that illicitly manufactured fentanyl is now becoming a key component of the opioid overdose death rates. The fourth bullet is providing support for cutting-edge research on pain and addiction, and as you've heard from my colleagues this morning, I think the National Institute on Drug Abuse is definitely leading these efforts, and advancing better practices for pain management. But just doubling back to providing support for cutting-edge research on addiction, I wanted to just highlight for you a new initiative that was just actually cleared by the Advisory Council for the National Institute on Minority Health and Health Disparities that's really going to focus on addressing the challenges posed by the opioid epidemic in health disparity populations. So just to highlight a few of the goals that we hope investigators will be able to address in their research proposals is looking at questions such as addressing disparities in access to treatment in rural settings, supporting community collaborations and partnerships to address prevention and intervention strategies, and examining health outcomes in opioid-dependent newborns in medically underserved communities. And at this point, I will stop so that we can have time to have conversations with you all. Thank you very much.
Thank you so much, Dr. James. So just to alert everyone, shortly we will be inviting questions from the audience, and we have 2 microphones at your disposal. So just feel free to proceed to the microphone, and we'll know that you are ready to answer or to ask a question. I will be posing maybe just a couple of questions to the panelists, and then we will turn it over to the audience. Dr. James, I wanted to ask a quick question of you. Thank you for that presentation. I noticed that on one of your slides that it shows that over a period of several years, the disparity between gender is actually quite significant. Are you able to comment on that, and might there be some genetic issues that we can consider as well for the reason for that slide?
Can you repeat the question, please, again?
All right, there was a slide up there that showed that there's a big disparity between the deaths among men and among females, and both are rising, but the disparity is pretty significant. Are there comments about why that might be?
I really don't know. Good question. It could be.
Oh, it's on. Yeah. Are you talking about the fact that there's more males than females and more whites than blacks and stuff like that? Is that mainly a gender issue? Yeah. Well, this is a little unusual epidemic because it's mostly affecting males and more middle-aged males. The rate of abuse in kids is actually going down a bit, but the overall death rate's going up. So why it's different, I'm not sure. There are some, Jonathan, you know about genetics and things like that. Women, I think in general, tend not to tolerate opioids quite as well. Some people get sick. They take them, they get nauseous, they don't like them. And that's not a road to addiction. It's a road to, I'm not taking these anymore. So some of it might be genetics with it. It certainly relates to the pain issue, because women have more pain in general, more painful conditions than men in general. So it shows a disconnect between taking opioids for pain and then becoming an addict. And that's something I'd like to, that connection is not that strong. There is an association, but most, as we've heard, that most people get it from family and friends and not just taking it as a pain patient. So again, I want to guard people in pain, especially both males and females, but not take them away when they're needed for either sex.
Thank you. The other question I'm curious about as I watch the microphones, in case individuals are interested, we'll be directing the questions to you in a moment. But I'm curious about the drug monitoring programs that are available. Are you satisfied with those? And how do you think they could be improved, if in fact you're not?
Do you mean the prescription
Drug monitoring
programs at the individual states? That is certainly a tool, and we've heard from the previous panel about how we're cautiously advancing that. Now, there are states, the problem is, even though it's in 50 states, the District of Columbia and Guam, every state does it slightly differently. They collect data differently, and they collect it on different drugs. So, and the programs are all state-based. And that's the challenge in general, I think, because to get results or to make sense of the data requires more time because of the fact it's not uniform. But it has shown that in states where there's a mandatory requirement to use it, that it's decreased prescription rates, so by as much as 10%. So I would say we're cautiously optimistic when it comes to this, but certainly more data needs to be obtained before we can say it's definitely working very well or not.
And I would just like to add that I think it was mentioned in the earlier panel that linking this type of program to electronic health records will definitely aid physicians in terms of providing adequate care and knowing exactly who's gotten what. I think that'll put it directly in the hands of the physician to provide better care for the patient.
Thank you. I'm curious as well, Dr. Haradi, about the FDA opioid plan, and what do you think we need to do in terms of, would you suggest any changes to that? And
Well, thank you for the question, Dean. I think the answer is complicated because, as you can tell, the plan itself is a multi-pronged approach, and also we're just one out of many that need to put our best foot forward in this situation. I think at first recognizing that perhaps in some areas of regulation we need to do better. In particular, there's some post-marketing studies that we've been tracking over the years that perhaps we can get more useful data out of that as far as we're starting to get some now. I mean, these programs have not been set up very long. Probably we are only getting 2 or 3 years worth of data, so it's very hard to speculate. On the other hand, I will say that our commissioner is very committed. He's been very aggressive. One example of that has been that for the first time this year, we have recommended a withdrawal of a drug from the market for reasons other than what it's indicated for. So, for example, in the past, we've recommended that drugs be removed because of safety and efficacy reasons when it's taken as indicated. And then, of course, I'm referring to Opana, which you all have heard of. That's been the reformulated Opana. And the problem with that is that when Opana was reformulated, they made it easier to inject. So even though it was harder to crush, for some reason it was easier to extract. And so people were dying not from using the drug properly, but from misusing the drug. So this is the first time that we've actually recommended that endopharmaceuticals withdraw the medication from the marketplace for a non-indicated reason. So things like that, unfortunately, there's limits to what we can do. I mean, the practice of medicine is not a federal regulatory function right now. And so until we get probably new legislative powers from Congress, I think the best would be to move forward with what we currently have.
okay. Thank you so much. I'm curious to come back to the precision medicine issues. However, I see that we have a few folks who are interested in asking questions, so we will start with you, ma'am. Please state your name and where you are from, and then we can...
Yes. My name is Beverly Anderson. I'm from Prince George's County, and I'm involved in community outreach programs and health.
Thank you.
You have mentioned the importance of education, mainly to patients, and general awareness of opioids. But I'm concerned, since it appears that there's an increase in the a number of our youth using opioids in high schools and in colleges. So I am concerned about the kind of education that can be provided to our children, maybe junior high school children or middle school children, in the area of prevention and the kinds of messages that could be conveyed to that group.
Thank you. Dr. Thomas, it looks like...
Yeah, I guess I'll start with that. Yeah, I thought that the rates were starting to dip down with the National Household Survey in terms of opioids and middle scores, but I'm not positive about that. But part of the education needs to be, I mean, these are readily available to teenagers and younger because they're in the house. So parents need to educate their kids that don't get these, or at least lock them away, and make it clear to them that these are not safe just because they're medicine, that you need to take them as prescribed. And that sort of message has to get out there more and more, because heroin on the street, it has a stigma, if you will. People are afraid of heroin, but they use it. But there's the idea that these are FDA approved, and you know what's in them, and you're safe, and you're not. You're not. And that's the parents, that's the kids. Part of the national pain strategy and NIDA in general is trying to educate the public and educate clinicians and educate everybody to use these smarter and not use them smarter.
Thank you. It looks like we have another question there, and I see you, sir.
Hello, everyone. My name is Mb Drame from the College of Pharmacy. I actually have 3 questions, but for the sake of time, I'll only throw 2 out there. One of them that was alluded to earlier was about access to opioids for minorities. And my question is, what are some of the strategies that are being utilized or reviewed right now as far as increasing access to opioids for minorities, while also making sure that we are reducing the number of deaths? Because that's a huge issue. I know in my training as a pharmacist, one of the things that I saw a lot when I was training, which was an unfortunate thing, was that minorities were getting turned away. And that was something that bothered me a lot. So I'm really curious about what the strategies are. And my second one is, you mentioned about the fact that we are not employing all the things that are necessary to be able to address this issue. And I'm curious if you've come across any best practices that we could look at. For instance, I know if I look at Canada's guidelines for pain management, there's a lot of reference as far as patients with psychiatric disorders, use of pain meds, use of opioids in patients with psychiatric disorders, patients with histories of abuse or misuse. And when I look at our guidelines here, they tend to be a little bit more general. One of the things that I am concerned about when it comes to that is as we begin to restrict, we will see also probably another issue, maybe a little separate, is people starting to get on buses like they do right now and going to places to obtain, these medications that they feel are needed. But I'm wondering again, what is our correspondence with our neighbors, Canada, Mexico, what have you, in order to make sure that we are addressing this issue kind of more holistically?
So we'll start with Dr. James.
So in reference to your first question in terms of access to opioids, as I mentioned in the presentation, studies have documented that African Americans as compared to whites are less likely to get opioids prescribed to them, even when presenting with pain. There are studies to document that. What there aren't a lot of is studies to document why. So again, as I mentioned toward the end, we do have a solicitation for investigators to really begin to look at that question and examine what are some of the underlying causes of why this is happening, and how can we address this so that we can move forward so that we can actually provide all patients, regardless of racial ethnic background, the appropriate pain medication. So there are obviously some, ideas, might it be physician bias and perception in terms of what the patient is seeking the opioids for. As I mentioned, also in terms of low-income communities, a lot of the pharmacies don't necessarily fill the prescriptions for those who live in those communities. So again, we're hoping that at least the solicitation that we're putting out there to begin the investigation will at least begin to provide us with data around why these things are happening so that we can then take the next step to address the issue.
Thank you, Dr. James. It looks like Dr.
Yeah, and just to follow up on the low-income neighborhood, Carmen Green's done a lot of work on this, and she's found that even in more affluent African-American dominant neighborhoods, that opioids aren't available in those pharmacies either. It's not related to SES, it's related to race, and then the prescribing thing is another thing. I've talked to some of the researchers that have done that. They said, well, in a way, it's good that they're not being overprescribed to black people, but on the other hand, that's racism. So it's not the right reason to do the right thing. In terms of pain treatments and what's the right thing to do, pain is almost like thousands of discrete diseases. There's all sorts of types of pain. There's not one drug that helps it, one treatment. It's got to be individualized. So we just have to do a better job in the whole gestalt with that. But one disturbing trend that I think you alluded to is practices that won't prescribe opioids, or if a patient has a problem with opioids, and a lot of people are in the middle with Steve's talk, there's the people in the middle. If they find somebody in pain that's having some problems with opioids, I'm hearing horror stories of patients just getting fired. It's like, we're not going to treat you anymore. And that's not a reason to fire a patient from practice because they have two problems. That's the reason to keep them in treatment, to help them with both of the problems. But the concern is that the healthcare system might be pushing some people out. And where do they go? I mean, they either suffer, or they find drugs on the street that could have carfentanil in it, or fentanyl, or suicide's a possibility. And so we have to make sure as we're moving forward that we don't crush people in pain.
Thank you so much, Dr. Thomas. We're going to direct the question to the audience.
Dr. John Harriet from FDA. Do you think that the blame on pharmaceutical industry for opioid epidemics is fair? My personal position is that it is not fair because there is no product in commerce that is not approved by the FDA. And I believe that the major problem is the channel of distribution. Wholesalers, retail pharmacies, doctors, and pharmacists. If we are not careful, we will end up not even having drugs for those who need the opioid. Studies on drug shortages have shown that the reason for drug shortages, among others, is due to overregulation by the FDA. And if the FDA begins to blame these pharmaceutical manufacturers, we will end up not having the drug. So my question to you is that do you think it is fair to blame the pharmaceutical industry for the opioid epidemics, given the fact that no drug can go into commerce without approval by the FDA? Another question is that what is FDA doing about prescriptions that are filled in other countries and that enter this country? Don't you think that that may be a major source of the opioid epidemics? Because if the products are not available, people will not be able to abuse the products.
Thank you for the question, sir. If I understand correctly, you're saying the commercial entities that are involved with the drug prescription, is that correct? Or?
But is it fair that we should blame the drug companies since before they produced the drugs, they were approved by the FDA? And what is your position around that?
Well, I think that, once again, that's a complicated question. And there are, historically, we've looked at drug approval as if there's a med need or unmet need, and then if the drug is safe and it's effective based on the scientific data that's submitted, then pretty much a drug will get approved. There, as used, again, it's not, there's been less attention traditionally paid to if the drug was not being used as indicated. And so that's a big change in their organization over the last several years. Certainly, I think that there's enough blame to go around everywhere. You know, whether it's prescribers, whether it's overzealous salespeople, whether it's regulators who didn't anticipate that this problem will get to the stage that it is now. So rather than say, you know, whose singular fault it is, I think that as a society we need to get together, regulators, scientists, patients, advocates, educators, and see how we can tackle this together versus saying, you know, certainly manufacturers will, you know, they want to stay in business. But we're also partnering with other institutions like the National Institutes of Health to look at alternatives. You know, opioids have filled the need for 100 years. Maybe now it's time to look at incentivizing, approving drugs that perhaps are not as addictive. So yes, thank you for the question, and it's unfortunately I don't know if I can give you an answer that.
Okay, the second question is, what is FDA doing about prescriptions that are filled in other countries that enter into this country?
Prescriptions that are filled in other countries that enter into this country. So, what is the FDA doing?
Once again,
Because I believe that is the source
that, you're
of
talking
the
about an
problem.
individual import, like if we're
Going to Canada, going to Britain to fill this prescription, to get these drugs, and bringing them into this country.
right. So you're talking about individual import of medications that they
Yes.
There are current rules that current federal law says that you basically can't import in large quantities. It has to be just for your individual use that you fill, you know, overseas for your individual condition. Our approval process is for marketing and anesthesia. So for a company to market their drugs here, they can't just say take a drug that was approved in Europe and just sell it here. So we have to look at all the data and approve it that way. So what you're talking about probably is more individuals rather than
Yes, individual.
and that's it's a complicated issue. It's a policy issue. Officially, the regulations say you're not supposed to do it more than just for personal use, and you have to obtain a prescription legitimately in another country and fill it there. So we don't basically fill scripts here for prescriptions that are written elsewhere, as far as I know. I mean, that doesn't happen very often.
Okay.
But-
So it looks like you wanted to say something, Dr. Thomas. I know we need to wrap
Well,
up this session.
yeah, I always want to say something, but I guess the problem is, and I've seen this before at advocacy meetings and all sorts of places, where you're trying to point your finger at, oh, you're the one that caused this. This problem is too big. There's not one person, one organization. This whole system is broken. We don't train doctors to take care of people in pain. We don't reimburse pain enough. We have a lot of the medications out there don't work that well or have pretty serious side effects. NSAIDs have pretty they kill people too. And so it's not that one group just decided to do a bad thing and we're in this mess. The whole system needs to be fixed.
Well, I want to thank you for asking us so many questions. I think this is a good time to wrap things up. I was going to ask about the precision medicine issues and what some of the new advances are, but I know you talked about a little bit of some of those in your slides. Was there one parting comment you wanted to say about what the future is looking like with precision medicine?
Well, I really think that we really have a great opportunity as healthcare systems start to genotype patients to identify who might be vulnerable to becoming addicted. And as we get better phenotypes for pain, we may also develop, precise medicines that might better treat pain and target the particular receptors. that are involved in pain or in suppressing pain, and be able to actually personalize those treatments. So, thank you.
Thank you so much. Thank you, Dr. James. Thank you, Dr. Pollack. Thank you, Dr. Thomas. And thank you, Dr. Haradi. I want to thank you so much for engagement with our session. And stay tuned. We will want to give them a little bit of a thank you gift before they go. Thank you again. Let's give them a round of applause, please.